Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone to week 5 of Basic Dermatology Curriculum organized by Saudi Society of Dermatology and Dermatological Surgery. My name is Leen Alturki and I will be the session moderator today. Firstly, I would like to welcome and thank you all for joining us today. This session is being recorded and it will be made publicly available along the course content on a society official platforms on a social media after the course completion. Today's session's plan will include the main lecture delivered by Dr. Lamia, followed by 5-minute scientific talk by L'Oreal. Please feel free to type your question in the chat at any time and we will address all the questions during Q&A segments at the end of the session. Our session today will be delivered by Dr. Lamia Alkaresh, Consultant Dermatologist, Pediatric Dermatology Fellowship at Northwestern Medicine University in USA, and Dermatology Residency Program Director at King Fahd Medical City. Thank you very much, Dr. Lamia, for joining us today. It's a pleasure and honor to have you with us.
Thank you so much for the introduction. It's my pleasure to be here with you today. Today we'll be talking about petechiae, purpura, and vasculitis. In our session, I have no conflict of interest, and in our session we'll go through overview of vasculitis, classification, clinical presentation of different type of vasculitis, and evaluation and management. First of all, we have to know important definitions about this topic. So petechiae is defined as a non-blanching pain
عفوا دكتورة لميا، الصوت مو واضح.
My apology, it was disconnected. Is my slide showing now?
أيوة دكتورة واضح، تفضلي.
So when you encounter a patient with suspected vasculitis, you have to look for examination clues. So the first thing is distribution. Is it over dependent areas, acral areas? Is there any mucosal involvement or not? Another important clue is blanching test. Does the purpura or petechiae, when you press it, or the cutaneous lesion, when you press it, does it blanch or not? So always keep in your mind, purpura and petechiae do not blanch. Palpability, you have to feel it, you have to palpate it. If it's palpable, indicates inflammation or vasculitis. And of course, very important to look for associated findings. Is there any fever, arthralgia, edema, or any mucosal involvement? We'll talk about general causes of petechiae, which includes increased intracranial pressure like Valsalva maneuver due to, for example, like excessive coughing or vomiting, platelet abnormalities either due to low platelet count, which is a thrombocytopenia, or platelet dysfunction. Infectious causes, always consider secondary causes like infection or medication such as anticoagulant or antiplatelets. Nutritional deficiencies, most commonly vitamin C deficiency. Causes of purpura includes vasculitis, most commonly leukocytoclastic vasculitis, and coagulation disorders. Also, vascular fragility should be considered, such as senile purpura or steroid use. Trauma and mechanical causes are also a common causes of purpura, and again, secondary causes like infection should be considered. Purpura can be divided into some types. So when we have non-palpable purpura, it means platelet or coagulation disorder. When you have palpable purpura, that means you can feel it. It indicates inflammation. Most common example is a small vessel vasculitis. We have another entity called pigmented purpuric dermatosis. The most common variant of this entity is Schamberg disease, as you can see here in this picture. It's an inflammatory purpura. It's a benign condition, usually caused by hemosiderin deposition. And again, another type of purpura is senile or actinic purpura that can be caused by vascular fragility and dermal atrophy that can be seen always on sun-exposed area in elderly patient, as you can see here in this picture. Again, a very important thing when you have a patient with suspected vasculitis, always rule out or consider red flags. So, for example, when you have purpura and fever, think about infection such as meningococcemia or sepsis. When you have rapidly progressive purpura, you will think toward DIC, which is disseminated intravascular coagulopathy, or vasculitis as well. When you have mucosal bleeding, think about platelet dysfunction. And if it's widespread necrosis, we will think about purpura fulminans. Here is a table summarizing the differential diagnosis of purpura, or how to narrow down your differential diagnosis, or how to establish a good differential diagnosis list. So first of all, what I would suggest to start sorting by the size of involvement. Is it petechiae, is it purpura, or ecchymosis? And if it is purpura, is it palpable or non-palpable? So we have here an extended like differentials for each type. We'll just mention the most commonly encountered conditions under each. So for petechiae, we generally classify them into two main categories. Is it due to low platelet numbers, thrombocytopenia, or abnormal platelet function? And also non-platelet etiologies, as what we mentioned earlier, like Valsalva maneuver, or another common cause is using the blood pressure cuff frequently. We call this sign Rumpel-Lead sign. And in case of macular, let me just, yeah, I think we're missing. Yeah, in case of macular purpura or non-palpable purpura, we'll think about coagulopathies. While in ecchymosis, it can be divided again. Is it due to coagulation disorder or due to poor dermal support of blood vessels? For coagulation, you have to consider medication use or vitamin K deficiency, and also other conditions like DIC in some patients. And under the category of dermal support, the most common example is either solar or senile purpura or steroid use. Always think about drug-induced condition. Vitamin C deficiency can be seen as well. So these are the most common type. And when we have palpable purpura, that means inflammation, inflammatory. So the most common example is vasculitis or leukocytoclastic vasculitis. Actually, small vessel vasculitis is the most common type of vasculitis encountered by dermatologists, but we have other type of vasculitis that will be explained in the coming slides. So as you can see here, we have different type or different presentation of cutaneous lesions. So in the first picture, we have the typical presentation of petechiae. Why in figure B, we have an example of solar or actinic purpura. So as you can see, it's distributed over photoexposed area, and the background skin also it has like some actinic damage. In C, we have the typical presentation of palpable purpura seen in vasculitis, while in D, we have like hemorrhagic blisters in acral areas. This in a patient with disseminated intravascular coagulopathy. Now we'll talk more about vasculitis. But vasculitis defined as the presence of inflammatory leukocytes in vessel wall with reactive damage to the mural structures of the blood vessels. While a leukocytoclastic vasculitis is like a histopathological term, usually used to define vasculitis of the small vessel, in which the inflammatory infiltrate is mainly composed of neutrophils. However, other inflammatory cells like neutrophils, like eosinophils, and lymphocytes can be seen as well. When we want to classify vasculitis is difficult, and we have a lot of ways to differentiate to classify vasculitis. However, the most common way to classify them is based on the size of vessel wall, and also the risk for organ involvement beyond the skin increases with the size of the involved blood vessel. What do we mean? It means the larger the blood vessels involved, the higher risk for systemic involvement. So the size of the involved vessel usually will determine the cutaneous manifestation. So let's talk about this classification first. So we have small vessel vasculitis, as what we mentioned earlier. This is the most common type encountered by dermatology. It involves vessels in the superficial dermis. It can be idiopathic in 50% of patients. Other types include IgA vasculitis, urticarial vasculitis, erythema levatum diutinum, or cryoglobulinic vasculitis type 2 and 3, while type 1 is vasculopathy. Again, always rule out secondary causes like medication, infection, and malignancy, also autoimmune disorder as well. The other category is small to medium vasculitis, which involves blood vessel in the superficial dermis to subcutaneous fat. The most common example is ANCA, antinuclear cytoplasmic antibody-associated vasculitis. We have microscopic cholangitis, granulomatosis with cholangitis, or eosinophilic granulomatosis with cholangitis. Again, even in this category, you have to rule out secondary causes. Then we have medium vessel vasculitis when it involves deep dermis to subcutaneous fat. We have polyarteritis nodosa and Kawasaki vasculitis. Large vessel vasculitis includes temporal arteritis and Takaizo-arteritis. Neither one typically presents with skin findings, to be honest. So mainly small to medium, or medium. Those are the types usually will present with skin manifestations. And we have other conditions with variable size of vessel involvement, like Behçet disease or secondary causes of vasculitis. Other way to classify vasculitis based on cutaneous involvement, if it's limited only to skin or with systemic manifestation, or histopathological classification based on the type of infiltration. We have two main categories: is it neutrophilic or lymphocytic? However, other infiltration can be considered like eosinophilic or histocytic. As what we mentioned, small vessel vasculitis is the most common type of vasculitis in our practice, and the most critical elementary lesion of this type of vasculitis is palpable purpura. So always remember, purpura in vasculitis or purpura in general do not blanch with pressure. So here we have a test, we call it diascopy. What do we mean by diascopy test? Is when we use a glass slide to apply pressure to the lesion to differentiate erythema secondary to vasodilation, for example, it will blanch. While in purpura or in vasculitis, which is due to extra vasated or blood extravasation, usually it is non-blanchable. So all forms of purpura do not blanch with pressure. And again, there is no like typical lesion of this condition, or there is no only one presentation. It can present with any other skin lesions, such as urticarial plaques, nodules, vesicles. So there's almost no disease-specific primary lesion or organ involvement for this entity. So it can present like target-like lesion, hemorrhagic blisters, urticarial lesions. All these can be seen. In medium vessel vasculitis, we can see this cutaneous manifestation. We call it livido racemosa. It's due to vessel wall pathology. So it is like partially blanchable, irregular network, larger branching and incomplete rings when you compare it to the one we know or more common livedo reticularis. So what is livedo reticularis? Livedo reticularis is a physiological condition usually due to cold exposure. So a way to differentiate between these two condition is that livedo reticularis usually disappears or fades with rewarming, unlike livedo racemosa. Livedo racemosa is always pathological. When you have like a similar, it can look like a similar to livedo racemosa, but the pathology is different. We call it retiform purpura. When you have retiform purpura, we call it retiform, which means angulated. This is due to vessel wall obstruction or vasculopathy. It presents as purpura with like central necrosis or ischemia. So this it should be differentiated between livedo racemosa and retiform purpura. Again, the same idea, other cutaneous manifestations can be seen, but again, the more or the larger the vessel is involved, the more like aggressive skin lesion you would expect because it's going to be deep, so you should expect like more of subcutaneous nodules, more of ulcerations. So all these can be seen in medium vessel vasculitis. Another when you, like there is like certain findings that can be seen more frequently in some types of vasculitis. For example, in ANCA-associated vasculitis, specifically microscopic cholangitis, we can see splinter hemorrhage in nail. So I always recommend in every patient do full skin examination looking for helpful clues. In granulomatosis with cholangitis, you can see a characteristic lesion called pyoderma gangrenosum-like lesion because it looks like pyoderma gangrenosum with the typical violaceous undermined border. Also, you can see more of the ulcerative nodules over extremities. And granulomatosis with cholangitis, again, you may see gingival involvement. They call it sometimes strawberry gum and oral ulcers. In eosinophilic granulomatosis with cholangitis, I always link it like eosinophil, so it will have like more of urticarial-like presentation. And you can see also more of like coalescing papules over extremities as well. When we evaluate a patient with suspected vasculitis, I always recommend to rule out secondary causes first because management usually is easier and it will differ than other condition and usually is like more benign and more self-limited. And again, why it's important to rule out secondary causes, for example, when you have infection and you start your patient on immunosuppressive treatment, definitely you will make the condition much worse and you will have consequences for that. So always rule out secondary causes. And again, as with any other condition, start with the basic things, taking a thorough history, including onset, duration of the disease, associated symptoms, the medical background of the patient. Medication is very important. Always do drug chart. And ask specifically about common triggers. Rule out infection, malignancy, and don't forget to do your full systems review. Another important point in vasculitis and in all conditions in dermatology, always consider mimickers, great mimickers, or condition that may simulate vasculitis or may mimic vasculitis. So here we have a common mimicker. So we have like typical like purpura mixed with clinically with the hyperpigmentation. So when we have like a clustered petechial hemorrhage on a background of yellowish brownish over lower extremities, with a closer examination or with your dermoscopic examination, you find like more of yellowish. This indicates hemosiderin deposition. So this is pigmented purpuric dermatosis. As what we mentioned, it's a benign, non-inflammatory condition, nothing to be done. You can reassure your patients. While you can have like more serious mimickers. So another mimicker is morbilliform drug eruption is more common, and sometimes it may show actually it's common like vascular vasculitic or hemorrhagic appearance, especially on dependent area. It may simulate vasculitis, but you have to do full skin examination, even if the primary physician, the referring physician didn't mention anything, do full skin examination. So you may find more typical lesion of morbilliform drug eruption. So full skin examination is a must. Another mimicker, when you examine this patient, you can see like perifollicular petechial rash. So upon closer examination, you find the hair looks abnormal. So we call it corkscrew hair. So this can give you a hint about a condition. So you will do a full skin examination and you found gingival bleeding. So what is the condition here is vitamin C deficiency. So the patient is having, yes, I see one of you saying scurvy, correct? So this is scurvy. Excellent. So always consider mimickers. Another important and life-threatening mimicker, when you have like vasculitic lesions with like some hemorrhagic blisters that may mimic vasculitis, but with examination, full body examination, you found the typical retiform purpura with central necrosis, so you have to rule out more serious coagulopathic condition. Investigations, we have routine initial investigations that should be done for all patients with cutaneous vasculitis, which includes CBC with differentials, renal and liver function test, urine analysis, stool test, inflammatory markers like ESR, CRP, and skin biopsy. Chest X-ray also can be done. We'll talk more about the role of skin biopsy in the coming slide, but when we do like more extensive workup, so more extensive workup can be considered based on the primary results or based on your clinical examination if you have other suggestive symptoms, or if you have like more of unexplained or persistent vasculitis for more than 4 weeks, then you should do further investigations accordingly, which includes infectious workup, connective tissue diseases workup, malignancy, signs of systemic involvement, microvascular occlusions, and don't forget to refer your patients to appropriate specialty. So vasculitis sometimes can be multidisciplinary, needs a multidisciplinary team. So we'll talk more about role of biopsy. We frequently encountered in dermatology like referrals for a patient with suspected vasculitis, lesions been there for like a week or so, and they want you to take a biopsy. So we should all agree that biopsy is mandatory in patients with vasculitis. It's needed, even if the clinical suspicion is high. It's for ethical and clinical confirmations. Usually we take 2 biopsies to confirm the diagnosis, one for histopathology or H&E and the other one for direct immunofluorescence. However, timing is very important. Timing is very crucial. You don't want to do, or you expose your patient to like unnecessary investigations that you know it will not help in diagnosing them. So for direct immunofluorescence, lesion should be less than 24 hours old. So after 24 hours, there is a very high chance to have a negative results. So how to know clinically? Because some patients, they will not be sure if it's like for 1 day or 2 days. They cannot be like precisely sure for how long it's been there. So clinically, lesion that looks erythematous but not yet purpuric or very early purpuric lesions, this is most likely it's been there for like 24 hours. So this is the perfect lesion for DIF. And for H&E, and again, one of the residents also, I remember I encountered this with the resident, is it lesional? It is lesional. We take a lesion, the lesion for a biopsy. And for H&E, usually from 1 to 2 days. Again, if you take like from older lesion, you will not see, it will be like resolving. And too early for H&E, you will not see the full classical type of infiltration of leukocytoclastic vasculitis. So how to know which lesion is the best? If it is purpuric but not yet pigmented or necrotic. When we approach a patient to treatment, the first thing you have to ask yourself, is this patient going to need a systemic treatment or not? So you have to think, or to see if there is hemorrhagic blisters, skin necrosis, ulcerations. Is it persistent more than 4 weeks? Is it recurrent, chronic? Is there any signs of medium or medium vessel vasculitis or systemic involvement? If the answer is no for these questions, so most likely your patient will be controlled with conservative management and topical treatment. Systemic immunomodulatory will not be needed as a first line. So usually we start with rest, leg elevation, compression stocking, oral antihistamine if it's symptomatic, topical steroids to minimize inflammation. And again, it's very important to rule out to secondary causes or to remove triggers if you have infection or drugs. And if yes, usually it depends. Again, approach should be individualized on each patient have different like individual approach. But like a classic treatment, if inflammatory vasculitis is there, steroid or systemic steroid, because you want something strong to suppress inflammation. But keep in your mind, steroid is just a temporary treatment. It should be tapered over 4 to 6 weeks. If the patient has more extensive, or for example has recurrent or more chronic vasculitis, definitely you have to consider other treatment option, or you have to bridge it with other systemic or non-steroid treatment. First line therapies include colchicine, dapsone. Again, treatment should be individualized. There is like no one approach works for every patient. Other options that can be used: azathioprine, mycophenolate mofetil, methotrexate, or hydroxychloroquine, especially in urticarial vasculitis. For refractory, difficult cases, we may escalate our treatment option like IVIG, rituximab, or cyclosporin. Now we will talk about common vasculitic disorders. The most common example we have is Hennig-Schönlein purpura. It's a form of a small vessel vasculitis that occurs primarily in children, usually between 2 and 11 years of age. However, the most common age group is younger than 5 years of age. However, if it's older than 5, it's considered one of the poor prognostic factor. It's due to immune complex vascular deposition of IgA. Common triggers include infection, such as upper respiratory tract or strep infection. However, other infectious causes can be seen. Drug exposure is less common in this entity, but it can be seen as well. So as you can see here, as what we mentioned earlier, there is no like typical lesion in all patients. Yes, we have like a classic presentation, as you can see here. This is the classic purpura of a small vessel vasculitis with a classic botic involvement. Early lesions sometimes can present as an urticarial lesion. However, you can find like central crust or erosion in some of the lesion, which can give you a clue. And here we have atypical lesion. This patient presented as an ecchymosis or bruise-like lesion without the presentation of the common purpura, and found to have small vessel vasculitis. Systemic involvement in this condition can be seen in up to 80% of patients. Skin is always involved. The classic presentation is palpable purpura with and buttocks and lower extremities. However, it may extend beyond this. It can be seen in abdomen and upper extremities, but it's less common. Usually, it regresses after 10 to 14 days. Joint involvement in 75% of patients in a form of arthralgia or arthritis. GI involvement is common also. Usually it's mild, colicky abdominal pain. It can be associated with diarrhea, melena, or hematochezia. Renal involvement is the most common and most serious organ to be involved, and always consider it, always monitor it. Glomerulonephritis can be seen in up to 50% of patients. Why is important? Because end-stage renal disease can be seen in up to 5% of patients. Orchitis also should be considered in young boys. The other entity that in vasculitis is acute hemorrhagic edema of infancy. Again, it's a form of a leukocytic clastic vasculitis characterized by a large purpuric skin lesion and tender edema. It has a characteristic clinical presentation. If you see it once, you will not miss it. Usually it occurs in infants and children between age of 4 months and 3 years, most commonly less than 2 years of age. It has the typical cockade or medallion-like pattern. It has the characteristic scalloped borders with central clearing. Acrofacial edema is common. However, the skin lesion may look like ugly and scary sometimes, but a clue is that the child will look healthy, non-ill appearing, we call it. He's otherwise healthy. He has like very mild or no prodromal symptoms. So this is a clue for this condition. So here is an a picture showing the condition. As you can see, the characteristic skin lesion in addition to the acrofacial edema. Another important and common actually entity is hypersensitivity vasculitis. It's a type of leukocytoclastic vasculitis involving primarily the skin and in most cases is secondary to drug or infection. This is the most common type of vasculitis we see in adults. Can be seen in children, but it's very less common than in adults. It presents with palpable purpura, but again, you can see like urticaria or any other clinical presentation. Usually it's asymptomatic. It may have like mild symptoms, and usually it has no systemic involvement. The last entity we will talk about today is urticarial vasculitis. We have two main types, and both types are more common in female, especially hypocomplementemic vasculitis. So the first type is normocomplementemic urticarial vasculitis. So we have normal complements. It's the most common type in up to 80% of patients. It is usually skin limited, and most of the time it's idiopathic, and it has like a better prognosis because it's self-limited. Hypocomplementemic vasculitis, it can occur in up to 30% of patients. It is highly associated most of the time with systemic diseases. The pathogenesis is due to immune complex vascular deposition in hypocomplementemic vasculitis, so you should expect low C1q or low complement C1q level. The most common trigger for hypocomplementemic vasculitis is systemic lupus erythematosus. However, it can be associated with any connective tissue disease or autoimmune diseases. It can be triggered by infection, some medications such as NSAIDs, MTX or TNF inhibitors as well, and malignancies like leukemia or lymphomas or gammopathies. Usually it presents with painful burning urticarial lesion rather than itchy skin lesion as seen in normal urticaria. Usually it's distributed in lower extremities and the trunk. And another differentiating feature is it lasts for more than 24 hours as compared to normal urticaria, which tends to resolve in less than 24 hours. Again, another clue is usually it resolves with hyperpigmentation or purpura. However, sometimes it will not, it's not like the standard. We have a lot of patients, when we biopsy it, it's more of urticarial vasculitis. But when you have this feature, this is definitely support the diagnosis of urticarial vasculitis as compared to normal urticaria. It may have concomitant angioedema as the normal or ordinary urticaria. And usually in this condition, recurrent episodes last like longer duration, last maybe for months to years. So here we have an excellent example of urticarial vasculitis. So you can see the typical urticarial lesion mixed with PIH and purpura. So in conclusion, petechiae and purpura are non-blanching skin lesion. Their size helps you to narrow down your differential diagnosis and eventually to reach the right diagnosis. Always rule out red flags, serious underlying condition. It's very important to differentiate if it's palpable or non-palpable. And again, you have to determine the size of the vessel involvement because it may predict the prognosis, the extent of systemic involvement as well. Rule out secondary causes and great mimickers. And always remember, in vasculitis, there's no one approach works for everyone. So by this, I conclude my presentation and feel free to ask questions.